Good afternoon. That's my disclosure slide. In Swaziland, we have a very high prevalence of HIV, and we've always adopted a progressive approach towards providing services for care and treatment. So my presentation is just going to focus on the lessons that we've learned in the implementation studies for test and start that have been taking place in the country. This is our gap towards the 1990. This slide is just to illustrate how much a gap we have towards achieving 1990 and the unmet need. Focusing really, if you look at the slide, we can see that the males show the greatest unmet need compared to the females. If we translate the implementation to 1990, we're translating our data from Health Management Information System. We feel that we are on track towards achieving 1990. However, there are some major challenges that we face, and that's the reason why we decided as a country that let's implement the test and start implementation studies. Since 2012, our country, we adopted the treatment as prevention framework, where at that time, it was called treatment as prevention, and we named our studies Early Access to Art for All implementation studies. So they've been taking place in two regions, in the Hoho region and the Swaziland region. Hoho region under MaxArt Consortium, and MSF Switzerland, which is assisting us in the country. So basically, we're looking at feasibility, acceptability, and looking at clinical outcomes of implementing test and start in a government facility where there are no other added resources, and implementing services as like any other facility in the country. So the two studies were not quite similar in that one of the MaxArt study design was step-wise implementation, and the MSF study was more prospective cohort study that enrolled all people who were coming in, and then compared standard of care to implementation or intervention sites. The lessons learned, one of the lessons that we've learned from the MSF study, which has reached its completion, is that there's relatively high acceptability of art initiation at 3 months in all the CD4 strata as shown. However, not within the same day as we would have expected people to initiate within the same day. There are various reasons that we can discuss why people didn't want to start on the same day of testing. And then what we also learned is that higher CD4 is correlated with higher retention. Unlike what we expected, we thought that perhaps those who are more healthier wouldn't be retained as well as those who are less healthy. But I think we do think that it makes sense because the predictors of early disengagement from care include issues such as HIV disease progression, which is here measured as CD4 less than 100, a higher WHO staging, and a lower BMI. So basically people who are quite ill. And we also learned that yet we expected that at 6 months, all people would have their 6 months viral load taken. We found that only 38% of the people who initiated ART had CD4 blood taken, which for us says a lot about the way our health workers are receiving the guidelines that we give to them. And another lesson is that for 95% of clients are virally suppressed at the last available viral load. But so we measured viral load suppression as copies less than 1,000 mils, 1,000 copies per mil. So basically, in our country, we feel that as we learn from these implementation studies, we take test and start as a bridge or as a vehicle that is taking us towards the 390s. However, we are cognizant, the studies are telling us that we need to to work on certain issues if we want to make sure that we reach the 390s as a country. And this includes targeted demand creation and testing results will result in higher yields. So we have experienced that if we go and look out for men as a target, we find that we yield higher results from them, or the yield is higher of HIV positives. But we've also found that there are some challenges on misclassification of HIV status. Some false positives are coming up, whereby perhaps people may not come out to say that they have tested before, or maybe our tests are revealing people who may not actually be positive. And we are working on such because it may have a bearing on the quality control or quality of our HIV testing procedures. And then although we've seen high acceptability from providers to the test and start approach, and people living with HIV also have accepted, we still are concerned about delays in client readiness. At 6 months for those who are initiated at CD4, for those who need to initiate ART as soon as possible. And then we are also worried or concerned about limited client-provider interaction, whereby we still lack that closeness between the health worker and the patient in order for the information to flow to the patient about the importance of beginning ART immediately. Then also we've seen that health workers will often delay the first viral load monitoring, which is a concern to us because we would like to achieve the third 90. And then the long turnaround time for viral load results could be the reason why health workers may not be motivated to even request for the first viral load test. Lastly, the clear communication strategy. We need to make sure that our clients really understand what we mean by undetectable viral load so that they're able to be motivated to accept or to demand the viral load testing. We saw a situation whereby in CD4 testing, our clients were demanding CD4 tests because they associated CD4s to their soldiers in the body. So now the question is, how do we ensure that they understand what viral load is without them having to admit that my virus is more or my virus is less? So there are some very, very sensitive information that we need to make sure that we work on. Lastly, our main challenge that we know is that our access to testing is still very low, and our studies didn't really go through the process or any approaches that will make sure that we increase demand creation for our people in order to test for HIV. Thank you.